Welcome, everyone, and thank you for joining us for the NCD Alliance Regional Multi-Stakeholder Dialogue in Eastern Mediterranean Region, titled Inspiring Change, Putting People First, Shaping Responsive Health Systems for People Living with NCDs in the COVID-19 Era. I will now pass the floor to Dr. Christina, the Capacity Development Director of NCD Alliance. Christina, the floor is yours.
Thank you, and good afternoon, everybody. I'm Christina Parsons-Perez, Capacity Development Director at the NCD Alliance. And so on NCD Alliance's behalf, I'd like to welcome you all to this multi-stakeholder dialogue for the Eastern Mediterranean region. And the name of this event is Inspiring Change, Putting People First, Shaping Responsive Health Systems for People Living with NCDs in the COVID-19 era. And we're delighted to have today panels of distinguished speakers and members of our NCD community, including people living with non-communicable diseases and other relevant stakeholders. Today's dialogue is hosted by the NCD Alliance with the support of Novo Nordisk, who work actively to prevent and control diabetes and other major chronic conditions through partnerships and advocacy work with the objective to accelerate action towards the achievement of global goals on health and the wider sustainable development goals. And we'd like to thank Novo Nordisk for their support and partnership. Now, for those of you not familiar with the NCD Alliance, we are a global civil society network bringing together a unique community of over 270 members in more than 80 countries, and we're dedicated to supporting a world free from preventable suffering, disability, and death caused by non-communicable diseases. Regionally, in the Eastern Mediterranean, we have 11 members, 5 national NCD Alliance members, and 1 regional NCD Alliance member. That's the Eastern Mediterranean Regional NCD Alliance, with whom we are proud to co-host tomorrow a regional civil society meeting following on from this dialogue. Now, all of our members in the region are very actively leading on advocacy, awareness raising, and providing essential support to people living with NCDs across the region. Now, we also work with governments, UN agencies, private sector, foundations, and other relevant stakeholders to translate global commitments and knowledge on NCDs into action, and help ensure too that good practice and evidence-based NCD policy implementation is shared through international, national, and regional forums such as this one. Now, today's dialogue is important and timely as there's been a real surge in NCDs in this region in recent years. Now, more than 150 million people were living with NCDs in this region in 2020, according to WHO, and the region has some of the highest NCD prevalence rates globally, with future projections indicating an alarming increase. And unless serious action is taken, we'll see 2.4 million deaths occur in 2025 due to cancer, diabetes, cardiovascular disease, and chronic respiratory disease. So this really represents a major burden, particularly so for those countries in the region that are low and middle income countries. Now, according to current data from WHO, EMRO, the COVID-19 pandemic has affected up to 22 countries within the region, with over 10 million cases and 205,000 deaths have been reported. And the NCD community is experiencing COVID-19 as a syndemic, with people living with NCDs severely and disproportionately impacted in several ways. Now, in this region particularly, heart disease, diabetes, respiratory disease, and cancer are the comorbidities most associated with COVID-19 patients. And we know that COVID-19 is placing unparalleled strains on health systems across this particular region and globally, creating widespread disruptions to access to essential medicines, as well as blocking routine health services such as screening, treatment, and palliative care. In some countries, with populations displaced by humanitarian crises. We're also seeing national health systems experiencing increases in referrals to secondary and tertiary care. We know that the pandemic is imposing extreme anxiety on people living with NCDs, for people who can isolate, and even more so for those who cannot afford to do so. So overall, COVID-19 has really exposed the damage that neglecting NCDs and cutting public spending on health prevention and essential public health services has done over many years in many countries. So to better protect those directly affected, people living with NCDs, there's an urgent need to revisit multi-stakeholder partnership models for the prevention, diagnosis, and treatment of NCDs. Now, whether this be simple, urgent bursts, short-term coordination across sectors like acute pandemic responses, or long-term collaborative problem solving for deeply rooted challenges, multi-stakeholder partnerships for NCDs must be driven by the needs of the most affected populations and acknowledge that value of the lived experience. Now, over the last 2 months, between May and June, the NCD Alliance, we've been hosting a series of regional multi-stakeholder dialogues in different WHO regions. And today's meeting is the final dialogue in this series. We've conducted dialogues in Africa, in Latin America and the Caribbean, the Southeast Asia and Western Pacific regions. So today's dialogue aims to take stock of progress achieved on NCDs and challenges faced at the regional level in the current COVID-19 context. We'd like to discuss the value of adopting people-centered approaches to address NCDs and exploring the role that different stakeholders can play, and also facilitate the development of a common vision and shared purpose across sectors and stakeholders, acknowledging different drivers and enablers to embed meaningful involvement of people living with NCDs in organizational practices. And we'll hear from panelists from different stakeholder groups, including development agencies, governments, multilateral organizations, and civil society, relevant private sector, and people living with NCDs themselves. And we will be discussing how we can ensure that policy frameworks, health systems become fit for purpose, reflecting a resilient and sustainable way forward by including at all levels those voices of communities and people most affected by decisions in health and development. Our discussions will be feeding into a broad consultative process that is contributing towards a global charter on meaningful involvement of people living with NCDs. The charter seeks to provide a shared understanding of meaningful involvement, why it matters, key principles and strategies for operationalizing, and commitment from different organizations to embed meaningful involvement of people living with NCDs in organizational practices. The Global Charter on Meaningful Involvement of People Living with NCDs will be launched at the 2021 Global Week for Action on NCDs this September. And NCD Alliance will be encouraging, well, the NCD Alliance and our community will be encouraging interested stakeholder organizations to endorse the Global Charter and to promote it. So now is the moment to prioritize people-centered approaches to address NCDs, ensuring universal health coverage and ensuring no one is left behind, so we can build back better and fairer from the COVID pandemic. And we look forward to a fruitful deliberation today. So with this being said, I hand over to Dr. Zied Mirsi, our moderator for today's event. And Dr. Zied is the co-chair of the Tunisian Center for Public Health, and it's our pleasure and honor to have him moderate our event today. Over to you, Dr. Zied.
Thank you so much, and thank you, Christina, for your wisdom and for these great opening remarks. It's a true honor for me to be your moderator today. I am really looking forward to an exciting conversation. We have a couple of panels. We have a fireside chat session, and where I will gonna be sort of like hoping that you get all the answers you need from our speakers. We have a great lineup of speakers, and I am going to be a moderator who's going to be a little bit, I would say, authoritarian in terms of managing time. So I will not speak much more than I'm allowed to, but I really want to offer everyone the opportunity to contribute. Feel free to share your questions, to raise your hands, to use the chat feature to contribute to the conversation and offer your remarks and observation to what our speakers are presenting today. I will not waste any single second, and I will go straight to our keynote speaker, Dr. Maher Rabat. We're really honored to have you on this multi-stakeholder dialogue, Doctora. Dr. Maher Rabat, for those who do not know her, she's the WHO Director General Special Envoy on COVID-19 Preparedness and Response. That's her current role. She has a long list of former roles that I will not even expand or try to list, but she's one of the leading professionals, leaders, activists, and analysts of public health in the region. And we would love to hear your thoughts, Doctora. You have 8 minutes.
Well, thank you very much. Can you hear me now? Can you hear me?
It's all clear. We can hear you.
Okay, well, thank you very much, Dr. Ziad and Dr. Christina, and thank you for inviting me to this very important discussion. And now we are at a point of our world is changing beyond imagination, and so is our region. So it's not only about the COVID and the pandemic and the NCDs, but the societies are already markedly affected by the inequalities, which are more affected by the COVID crisis. So we have a situation here. So the countries in the region, they are faced by many challenges. And I don't want to repeat what Christina has just mentioned, but as well, we need to understand the challenges facing the countries. They are attempting at one point or another at implementing complex health reforms, of course, with disparities among and between countries. They are markedly and have been markedly affected by the COVID pandemic, disruption of the essential health services, on top of which we find the NCDs have been markedly disrupted. It has underscored the inequities and the vulnerabilities. And as well, there has been for some time now recent shifts in the needs, whether economic needs, the social, demographic, the epidemiological transitions, which have put their impact on the communicable and the non-communicable disease epidemic as we see it. And there are political instability, disruptions, conflicts, emergency, humanitarian settings. So we are having a challenging situation in the region. And this is compromised, or this is really affected as well with the rising health costs, with the resources that are needed, with the healthcare services facing the budget constraints, the resources, as I mentioned before, and as well, it is how we are putting this into the oversight of the needed change, the oversight of the quality of services, the emergencies, the fragility, the patient and the client powers, and the aging of the population, the climate changes, and with healthcare for all and leaving no one behind. So at this point, it is very important to envision how do we envision health sector and health service delivery as a whole, and for non-communicable diseases per se by 2030, 2050, and beyond. It's the what and the how. So we know that we're always saying we're building forward better, we're building forward stronger with resilience, but we know that the governments, they need to protect the health and the livelihoods as part of integrated response. So it is integrated response to leave no one behind. And at the same time, for NCDs in particular, increasing the compliance, increasing the commitment not only of the governments, but of the individuals and the communities themselves towards healthier quality lives. We're talking about increased life expectancy, but we have to align it with the quality increased life expectancy and aging and what is expected and what is happening and the burden of the NCDs as we see it. So it's how to involve the stakeholders, increase responsiveness and resilience of health systems. And here I would like to say responsiveness and the sensitivities of the health systems to the increased needs and demands and aspirations of the people. And this is the time to urgently scale up all the efforts to transition towards the universal health coverage. So for the non-communicable diseases, we know that our region constitutes a great burden. The NCDs constitute a great burden in our region. And if no strategic interventions are not taken, the burden is forecasted to increase. And there are different causes for this. So we have increased life expectancy, but it's doubtful the quality of increased life expectancy, the impact of the aging populations, and as well, we know that the burden of death is highest in the region due to the NCDs. So, as well as Christina mentioned, expected to be increased by 2030 if no interventions are properly undertaken. So there are many reasons for this, and we know that particularly in our region, there is disproportionate affection by NCDs due to the urbanization, due to the globalization, due to the unhealthy behaviors, but as well due to the socioeconomic and the social determinants of health, which affect the people and the communities negatively, as we are talking about the challenges that are faced. And we know that the health systems, they are challenged by the fragility, they are challenged by the needed change, and as well with the prolonged political unrest, the conflicts, the emergencies, the poor data systems, the poverty, and the disparities displayed across and between countries as well. So moreover, we know that the EMR countries have health systems whose structures are not really adapted or designed in order to really tackle the issue of NCDs, not only as per the management, but as well for the promotion, prevention, and early detection as well. And we know that we are in a situation where the COVID has really unpacked all this fragility, has really unpacked the weakness of the health systems, the unpreparedness of the health systems, not only to tackle the emerging pandemic or outbreak, but as well to encompass all what is needed to satisfy the health needs, particularly for the NCDs, as we're mentioning it. So in some places, the pandemic has exposed this fragility and the weakness, and as well the way the health systems are organized, the way the health systems are really responding to the needs and the healthcare. And what is really important is that the starting point here, we have to admit that the starting point for NCD management, particularly at the time of the pandemic, is not the same for everyone due to the disparities, discrepancies, even in between the countries and in the countries themselves. So, but now we have to say that more than ever, it's important to reaffirm the interconnectedness of the communicable diseases and the NCDs and the importance of public health systems, as we're mentioning. And it has been mentioned, and now I am really affirming that studies have reported that in the EMR, the highest average disruption of essential health services has been found or has been detected in many of the countries, and the existing infrastructure have been repurposed and for other reasons. And that is why the United Nations Department programs of NCDs COVID-19 vulnerability index has shown all of those variabilities. But as well as we're talking now, I would like to go to one issue, which is that our failure to invest in the NCDs and the COVID-19 situation has exposed how vital it is now to invest in healthy populations and to strengthen the health systems. So putting people first from a vision to implementation, we know that we have to put people first, hear their voices, see their aspirations. But this is a call to elevate the voices of people living with NCDs, whether they are youth, women, indigenous populations, people in emergencies, to meaningfully involve the civil society and the multi-stakeholder endeavor as being supportive of the country governments and the ministries of health, as we're talking in allowing the services, the NCD services in the national primary healthcare packages to both stable and emergency contexts. So in healthcare, we know that this means that there should be a transformation to achieve and maintain healthy and quality of life of people or groups of people. And this transformation means that we are shifting the way we are organizing the health systems, the way that we are leading out or reaching out to the stakeholders and integrated coalitions and models of services. But first, we want to understand, what do people want? So people have higher expectations, and those living with NCDs, they have those expectations, particularly because they are living, there's not only one NCD, but with multiple STDs and NCDs as well. So they need to meet their own particular circumstances. They want greater control over their lives and the risks they take. And they want it to be done with dignity and respect, to be at the heart of any interaction, so that they can access high quality services and support closer to where they want it to be accessed in the right time or at the right time. So putting people first confirms that the reform can only be delivered through partnerships, multi-stakeholders models and approaches that enable satisfying individuals' aspirations. And to be able to do this, we need to bridge the gap between what is and what is needed to build forward better. This requires data, requires tools, services. We need services that really is tailored to the promotion, prevention, and is shifting away from the clinical management part. We need the screening, the diagnosis, the surveillance, and all this has to be packaged in a way that would really bring people first and to provide the health care, the health and care that is really important to them and satisfies their aspiration. And at the same time, it guarantees the effective production of health and the effective production of the required outcomes for quality of health. So we have to understand that it's not only about money, but it's only as well about that we know where to direct the tools, where to direct the strategies, and how to implement them in a way that would really improve the outcomes, and in a way that the health services and health sector can manage it over time. So this requires responsiveness, sensitive health systems, as I mentioned before, data and to do so, we need to see putting people first as a tool as well, and not only an objective. So yes, it is an objective, but it is a tool as well for improving the sensitivities and the responsiveness of the health system. The implementation requires strategies with right level of granularity. And here we need to ask ourselves, during the past decades, have we been doing or have we succeeded in reaching out and putting people first or not? Have we allocated the best resources and investments to do this? And despite the progress made so far with the NCDs and with the work of the WHO, with the countries, with the innovations, and with the countries and communities interventions, like in Egypt, we have the 100 million Sahha, which was really targeting people with NCDs, I mean. So far have governments proportionately matched the epidemiological need for NCDs with actions taken? This is a very important question. Have we invested well in this? And is there a way of advancing health systems for the development of universal health coverage? These are questions that we need answers to. How can we strengthen the communities and people's role in this development? How can we improve and empower and increase their engagement? And finally, putting people first and needs an inclusive approach, as well as the availability of everything or all actions and strategies, policies and laws, and involvement of the multi-stakeholder models in order to be able to really facilitate the environment required for tackling NCDs. So we know that the novel coronavirus has exacerbated the deep inequalities in our societies, highlighted the need to invest smarter to address health needs of people living with non-communicable disease. But as well, we need to acknowledge the fact that COVID-19 is but a trigger for the increase of the NCDs even after the pandemic. And we have to have this oversight and the proactive measures to really encompass the newer epidemic that is going to face, the whole world is going to be faced with. So it's the approach cannot be the business as usual, requires proactive, practical, innovative interventions to overcome the current disease-specific approach, which will not be sustainable. And now we have to say, and I don't want to take much more time, that the growing epidemic poses urgent need for transformation, for the shift to strengthen the health systems, and at the same time, as the words of the WHO Director General, Dr. Tedros says, it is now. If it is not now, then when? Thank you very much.
Thank you, Dr. Maha. It's very inspiring to hear you knowing how much you have done in the past and you coming to us with all these questions. I think it's a moment for reflection for everybody, and I cannot dream of a better lineup of people who could give us some answers to the questions you've been raising. I agree with you, we should be putting people first, and that's what I felt throughout this program. And that's also what I felt throughout the actions of many of you who are present today. So in order to embody what you said, putting people first, I would like to invite our next speaker, Dr. Omar Abu Reish. Dr. Omar is a medical doctor from Amman, but more than being a medical doctor, he's a cancer survivor, and he's somebody who's really sort of like know the system inside out, both from a provider perspective, but also from a patient perspective. Dr. Omar, we're really happy to have you on the event today, and would love to hear your thoughts.
Hi, everyone. Thank you, Dr. Zaid. My name is Omar Abu Reish, and I'm speaking to you all as a person who have lived with an NCD. I have lived with leukemia for almost like 4 years. And also I'm speaking to you as a medical school graduate. I've graduated from medical school this month. The reason I have mentioned these two pieces of information about myself is these two things help me to form the idea that I'm going to mention. First, when I was in a medical school, I used to study and try to understand and memorize a variety of diseases and conditions. But I think I didn't have like a better understanding of any disease the way I did understand leukemia. The reason behind that is because I have lived the disease. I haven't just studied the disease. I haven't just read about it. I have lived the disease. So this thing, I feel like I know more than just studying or reading about the disease. So I reached a level that I feel like I know more about leukemia than all the physicians in the world because I have lived the disease, not because I'm smarter, but just because I have lived it. So starting from this point, we can see that patients, we know more. We know things that not everyone can know about the diseases and about the treatment, about the management we had. Let's take COVID-19, for example. In our region, when the COVID-19 hit, we had like a huge shift in the healthcare services, a huge shift in the decision and policy making in the government, all toward the COVID, all shifted to face COVID. The thing that left a lot of patients with NCDs, patients of diabetes, patients of cancer, with no access to facilities, with no management. Patients couldn't get medications because of the quarantine and such things. So we had a bad results. We had a bad outcomes in the terms of health of these patients. So if we just can imagine if we had a person who had an experience with NCD, who have lived a disease, in the position of decision making or in the position of policy making. We wouldn't have that huge shift, and we wouldn't have that huge impact of the COVID crisis on these patients. So starting from this, I believe putting patients first is not a thing just we can advocate or ask for. I think it's a must. I think it's a must, putting patients first in the terms of policy making, in the terms of decision taking. This is the idea that I believe in, and it is the title of this webinar. This is the idea we all advocate and we all share. This is what I want to say, and that's all for me.
Thank you so much, Omar. Please, if you have questions for Omar, feel free to ask them. I really appreciate you taking the time to share your experience, but also to come out. I think we need more people like you. We need people to speak up. The ones who kind of saw the system on the inside and are the ones who know better what we need to do and what needs to be done. I congratulate you for your medical degree. This is a huge accomplishment. I hope you'll stay in the region to help us improve the situation and work on sort of like building these reforms and the transformation that Dr. was mentioning. And we can only transform it with doctors and young doctors who are committed to the cause, just like you.
Yeah, sure.
So I would love to kind of like offer the opportunity for people to ask some questions in the chat, but I know we're also a little bit tight on time. I would basically just go back with Dr. Maha. There is one question that we received in the chat regarding basically her recommendation for caring patients with common but neglected NCDs. I think this is something that deserves a lot of investments, a lot of focus. I was wondering, Dr. Maha, if you have some thoughts. Our colleague who's asking the question reflected to one of the neglected NCDs like the Burger disease. But overall, I think NCDs is such a big bucket, and WHO has done some sort of prioritization that doesn't take some of these diseases into consideration or doesn't consider them a priority. As someone who worked in the region and who basically invested your time and then also came up with a sort of prioritization when it comes to NCDs within health systems, I was wondering if you have any thoughts on that.
So, well, okay, thank you very much for the question. And really the question does not only go for this particular disease, but it goes for many of the other diseases, which are NCDs, I mean, which are neglected and they are not prioritized. So we need to revisit the prioritization issue. Is it about the numbers, or is it about the cost effectiveness of the interventions and the management? So it's how we are prioritizing the issues, and as well the cost benefit issues. And this is really against, I would say against the rights of people who are seeking the management of a situation, I mean. But this requires like revisiting of the whole process of prioritization, the cost effectiveness part, the cost benefit part, and as well about the technology and the technological advances in attacking or in managing certain diseases. It has to be fulfilled. But as a decision maker, I would love to say, and this is really very critical, that there is a point where, or a frontiers where you have to extend, expand, or stop to find some other alternatives. And here, when we are talking about NCDs, the modalities for financing has to be revisited, and as well it has to have the responsibility of all stakeholders and the communities as well, in order to find ways and pathways of addressing all NCDs and not only the prioritized ones. So thank you.
Thank you, Doctor. This is a big topic for conversation, and I think a lot of people have similar concerns when it comes to other diseases and the prioritization issue. I think our next panelist could also cover this topic, but as we have a very heavy lineup, the persons of Dr. Asmus and Dr. Abdullah and then also Dr. Ibtihal. Those are, few are on the call. And if you don't know at least one of those speakers, it tells me that you're new to the region. We have here the heroes of NCDs, the ones who have been working on this for a long time, the ones whose experience can enlighten us for the transformation that Dr. Maha has asked for. So basically, I would not speak any longer, and I'll bring Dr. Asmus first. Dr. Asmus is the Director of Non-Communicable Diseases and Mental Health at WHO EMRO. Happy to see you again, Doctor. I think we met in Dubai a couple of years ago. It was a pleasure to hear your thoughts and hear you present best buys. I remember that, and I'm wondering if we can revisit that list as it relates to prioritization. But I think the question that we have for you first and foremost on this panel is basically related to the intersections of NCDs and COVID-19. We heard Dr. Maha, she said that COVID-19 unveiled the weakness of our health systems, showed gave us a real reality check of where things stand when it comes to NCDs, and she called for a transformation and a new era pretty much on how we could do things differently. So I'd love to hear your thoughts basically on how we can sort of like start working on putting the people first as she advocated for it, and also increase the level of equity that we have in the region. You have 6 minutes.
Thank you so much, and it's a great pleasure to be with all of you today. And I think Dr. Maha and other speakers have beautifully set the scene for what I would like to share. So in our region, the Eastern Mediterranean region, which obviously includes the 22 countries between Morocco and Pakistan, NCDs and mental illnesses, and I would like to mention that because, as we all know, at the UN General Assembly, our member states agreed that mental health should be part of the package, are a significant public health challenge affecting over 150 million adults. And NCDs cause premature death and disability, increase healthcare costs, and hamper development in countries' ability to reach the health and NCD-related sustainable development goals. And I think this is important to mention because we have hard and fast indicators and targets on NCDs for 2030. So our region, the Eastern Mediterranean region, currently suffers from some of the highest burden of NCD-related risk factors, such as tobacco use, physical inactivity, obesity, and oftentimes a diet high in salt, sugar, and fat. And progress at national level in many countries in the region is unfortunately off track to achieve the SDG target 3.4, which is to reduce premature mortality from NCDs by 1/3 by 2030. So in fact, progress has been affected, as was mentioned, by the ongoing COVID-19 pandemic, exposing the vulnerability of people living with NCDs, while also revealing weaknesses in health systems and the need to strengthen NCD services as part of other essential health services disrupted by the pandemic. And we have seen significant disruption of health services provided to NCD patients in the region. A WHO rapid assessment of COVID-19 impact on NCD services conducted by WHO in May 2020, along with the second round of a WHO Pulse survey completed in April 21 in 135 countries and territories, including the EMRO countries, of course, highlights persistent disruptions to health services at considerable scale over 1 year into the COVID-19 pandemic, with 90% of countries reporting one or more disruptions to essential health services. The most extensively affected services are those for mental, neurological, and substance use disorders, cancer screening, and other NCDs such as hypertension and diabetes, urgent dental care, and malnutrition. And over 40% of the surveyed countries reported disruptions in these types of services. So in addition, the region suffers from chronic unrest and emergencies, as was mentioned by Dr. Maher, increasing the vulnerabilities of people living with NCDs in those settings. And for instance, since the conflict in Syria began more than 9 years ago, 5.4 million refugees have fled to neighboring countries. The burden of NCDs among Syrians is estimated to account for more than 45% of all deaths in this group. And Syrian refugees living in the region face extra challenges during the COVID-19 pandemic associated with interruption of medicine supplies and access to healthcare and loss of family incomes. While there has been widespread acknowledgement of the importance of engaging people living with the diseases within the global health agenda, valuing their voices, expertise, and inputs from design to implementation to program evaluation, and acknowledging them as crucial drivers of NCD policy processes remains an important area of development. Here, few models exist to date where meaningful engagement of people living with the diseases have been sustainably implemented, and if so, there remains a lack of evidence of whether these engagements have been successful. This is unlike the engagement successes in, for example, the areas of HIV/AIDS, TB, and other infectious diseases. In the EMR today, patient engagement has largely been untapped as a resource, not only for health providers, but also for political leaders and for civil society. This is exacerbated by the lack of data on people living with the diseases in general, specifically in relation to their multimorbidity. With the COVID-19 pandemic, we have a deep concern that many people living with NCDs are no longer receiving appropriate treatment or access to medicines as they did before. Well, WHO, as the world's leading public health agency, recently conducted in December 2020, in fact, an informal consultation on people living with NCDs, inviting CSOs, patients, and other stakeholders to share and discuss best practices of engagement and to brainstorm on how to foster more meaningful engagement of those individuals. At WHO EMRO, we will continue to advocate for the crucial role of people living with NCDs, engage them, and foster and expand community mobilization in our joint efforts to build back better from the COVID-19 pandemic. There's a clear opportunity now to build on the momentum of the increased recognition of meaningful involvement of all people living with the diseases we are talking about. I thank you very much.
Thank you, Dr. Asmus. I appreciate you respecting the time, and I look forward to continuing this conversation with the Q&A section afterwards. But I will go straight to Dr. Abdallah. Dr. Abdallah is a consultant for the GIZ, and I want to hear from Dr. Abdallah basically from where he stands. How's COVID-19 and has the pandemic sort of like really created this moment? Our organizer would call it the light bulb moment for public and political perception of the importance in investing in NCDs. Are you aware of anyone sort of waking up at this time and sort of showing further commitment to NCDs, Dr. Abdallah? Or basically, are we gonna go, as Dr. Maha said, do business as usual, and that's something that we would love to see change in the region? I'd love to hear your thoughts.
Assalamu alaikum. Thank you, Zaid. Warm regards to everyone. Thank you to to NCD Alliance for organizing this series and giving me the opportunity to participate. It is a pleasure to be part of this discussion. The topic of NCDs and COVID-19 is very close to my heart because while serving as the head of the National Cancer Control Program and founder of National Cancer Control Program in Afghanistan, I had the honor to serve with the newly established COVID-19 emergency response and health system strengthening a department between March 2020 and December 2020. Let me tell you a little bit about Afghanistan. I am following the NCD Alliance sessions in other regions, and also I think it is important to know that there are cultural diversity and geopolitical differences in different regions, and of course, even among the EMRO countries. Afghanistan has almost 35 million population based on the WHO, based on the World Bank actually report that there are actually 72% of people living under poverty as compared to 54% in 2019. And of course, COVID-19 played a major role in this, sadly. And according to Asia Foundation survey, 74% of respondents reported that their family members have not received any assistance from the government as a result of pandemic. In addition, our literacy rate in Afghanistan is 43%, which is the lowest among EMRO countries. One more thing that I would like to add, because these are all the determinants of health, is that during 24 hours, we have a few hours of electricity. This situation might be a bit similar to some countries in the region or some countries in the world like Syria or Yemen or Palestine, where we see war, but different from the rest of the countries in EMRO region. In addition to this deteriorating situation economically, Afghanistan is in war for the last 40 years. Currently, the moment I'm speaking, fighting is going on in around 200 districts between Taliban and the Afghan forces, the government forces. When it comes to health system, primary and secondary healthcare services are provided by non-governmental organizations, which are mainly funded by the World Bank, USAID, and European Union. The more than 70% of out-of-pocket health expenditure is out of pocket. And of course, many of the services and interventions for NCDs are not included in the primary healthcare package. So this is the situation of healthcare system in Afghanistan. Despite all these adversaries, the political and government response to COVID-19 is amazing. For example, for the first time, the government leadership, the president presided and administered a health issue, which was COVID-19. He is administering and overseeing this whole activities in the fight against COVID-19. And the other thing which happened is, as the result of COVID-19, the advocacy efforts brought about $1 billion to Afghanistan to fight against COVID-19. And another thing, what happened was the death of non-social and political figures, including the fourth highest ranking official after the president and two vice presidents, which highlighted the importance of chronic diseases such as diabetes and hypertension among the public and, of course, among the politicians. As the public is concerned, several knowledge, attitude, and practices studies show that knowledge about NCDs and their risk factors have significantly increased. We saw that the knowledge is more than and above 90%. For example, they do realize the importance of healthy food, including vegetable and fruit, and prevention of COVID-19, as well as of several NCDs. However, the question is, has the government and the Ministry of Public Health in particular prioritized NCDs during response to COVID-19? No, sadly, it has not. The Ministry of Public Health and the NCD Prevention and Control advocates has not been able to improvise this opportunity, despite the fact that COVID-19 has highlighted enormous burden of NCDs placed on health resources. COVID-19 should have acted and still can act as a catalyst for government and civil societies to develop policies and implement interventions to reduce risk factors, enhance diagnosis, standardize treatment, and strengthen disease research and surveillance. While NCD Alliance and other global agencies are working on strategies and interventions to better tackle NCDs, I would like them to consider the nations and communities who are caught in continuous civil unrest, war, and are refugees in neglected countries. Can we work on a health system where, despite all these miseries, we can have intervention and strategies to prevent and control NCDs? In Afghanistan, despite all these challenges, we were able to do some improvement in healthcare services. For example, before COVID-19, we had only 3 oxygen plants in whole Afghanistan, but now we have more than 15 oxygen plants, and we are going to have oxygen plants in every province and tertiary healthcare services hospitals. We didn't have a single PCR in public health laboratories, but now we have more than 25 public health labs equipped with PCR machines. So these are some of the improvements and accomplishment that we had. But still, we could have done a lot for prevention. We could have done a lot regarding reducing risk factors, and we could have done a lot incorporating NCDs in the response to COVID-19. Fortunately, I was involved in the development of COVID-19 emergency response and health system strengthening planning for the first, second, and third wave. It is interesting to know how the planning process went from being developed by the few directors in a one room at the Ministry of Public Health to going to develop by and share to different ministries, relevant ministries, all the departments within the Ministry of Public Health, all the donor agencies, the implementing NGOs, to provincial and district governments, and of course to community elites and leaders. I think this is the opportunity that was availed, and now sharing this plan with almost all people involved, we can make also them responsible, and they can see themselves in this plan developed to tackle COVID-19.
Thank you, Dr. Abdullah. I think this is very helpful for us to understand how basically on a national basis the dynamic that's going on in terms of leveraging COVID-19 for health systems, and then how we can squeeze in the NCD agenda in the current COVID-19 response. It's really heartening to hear about the level of funding and the commitment of the different players coming together to work as one team. I really feel like this is something that that we should be celebrating, but also in the same time, I hear your call. You definitely feel that there is more that could be done. There is more that we should have done. And also the crisis is continuing. And as we build better health infrastructure, I hope it will be inclusive, and that will take sort of the need of the patients in a wholesome way and in a comprehensive way. Thank you for these inspiring thoughts and for really giving us the picture and so many colors of what's going on in Afghanistan. And I'll move to Dr. Ibtihal to speak and sort of give the final remarks of this first panel. Dr. Ibtihal, it's a true pleasure. You're the leader of the Eastern Mediterranean NCD Alliance. As a co-founder of the Tunisian Center for Public Health, we're really grateful for all the work you've been doing for civil society in the region. You've been also our voice on the board of the NCD Alliance, and we want to thank you for your tenure. I think you put the bar very high in terms of like what civil society and what we could do in terms of advocacy. But I think having you today is an opportunity for a lot of our attendees to kind of hear from you some examples, some concrete things that you feel basically that can highlight the role of civil society in advocacy for prevention and control of NCD.
Good evening. Thank you, Zia. Thank you very much. I would like to start thanking the NCD Alliance for their leadership effort to advocate for people living with non-communicable disease and their support to the regional activity as always. I also would like to thank all the speakers for their great insights as well as their support for the regional agenda for non-communicable disease. It has been well mentioned by the previous speakers that the region is expecting a higher increase of non-communicable disease. This meaning there will be a higher number of people affected with the non-communicable disease. And also, as mentioned by the previous speaker, there is a considerable number of people who are living with non-communicable disease who are refugee and people who are displaced. So I think we are here in this dialogue. It is timely to talk about the best approach, how we can evolve and deliver the best approach for the non-communicable disease agenda in our region. And we need to accelerate that agenda, make it inclusive and agenda in a way of leaving no one behind. I think one of the main things we have learned from COVID and exposed the COVID, while it exposed really the weakness of the health system and the gap, which has been clearly mentioned and rightly said by the previous speakers in the NCD response, yet COVID is regarded as an opportunity to scale up and acknowledge that there is millions of people who are in the region living with non-communicable disease, and these people have a well-positioned experience that could be having a great input for the NCD agenda. I think in terms of our context and our discussion today, when we're talking about meaningful engagement of people living with non-communicable disease, it's not a new. This has been mentioned by the United Nations Political Declaration in 2018, as well as in the Universal Health Coverage in 2019. Just a few words about our civil society. We are a civil society, the regional NCD Alliance. We are a member of the global NCD Alliance and a group of a very well functioning civil society. They have contributed tremendously during the COVID, during the last 18 months in this challenging time. They contributed tremendously to the NCD agenda as well as to the health services and the social services in their country. So we have example from many countries where the civil society have provided health services, they provide medicine, they provided food, as well as the normal, function, like they provided a lot of information related to how to maintain services during the lack of or disruption of health services during that time, plus information using social media, all different way of social media. We have seen example in the Gulf region where they have accommodated for different language or if different culture of people to have messages for the people affected with non-communicable disease. Despite, I want also worth mentioning about our regional activity. So we have been working with the Global Alliance to enhance the regional capacity of the people living with non-communicable disease. We have started in early 2020. We have done a consultation with people living with non-communicable disease prior COVID and after COVID about their challenges, about their needs, and we have reported that, as well as we have done a series of capacity building of specifically focusing on refugee and youth. We want them to be able to articulate their voices on a global, local agenda. And we could see Omar, we are proud that Omar is one of the people who have been trained with our View, Our Voices training program. And we are counting a lot of these youth people who are affected, who can be an advocate for NCD. And we will be going to listen also to one of the refugees who is also going to speak about their challenges during this time. I think during this period, as a civil society, we have a critical role to mobilize the community, to move into better engagement of people living with non-communicable disease. We need also to value and respect the experience of these people. And I'm calling on all professional and policymakers to position that statement in their thinking and in their policy making to better engage people. And I think this consultative process will be well leading into better understanding of how we can fully engage people. Over to you. Thank you.
Thank you, Doctor, and I can't agree more with you. We totally need people like Dr. Abu Reis to kind of jump in and be the next generation of change makers in the region. We're a little bit behind schedule, so I think we're going to try to kind of save some time in the future upcoming sessions. But before that, I really wanted to show this video segment from the BBC, and I think this will tell a lot and give a lot of colors of what our panelists have been talking about so far.
تركنا بسوريا، انضرب البيت. كنت عايش مبسوط بسوريا وكان كل شيء متوفر والأمور كويسة. عندي بيت، عندي دكان، محل ألبسة، وعندي سيارة. أم خالد زوجتي تم بالدكان بالبيت. منحاول نشم ريحة الضيعة. عايش أنا ومرتي وولادي وكنتي.
هلا بدنا نطلع السوق، بدنا نجيب الطبخة.
نروح على السوق بنشوف ايش طلباتنا، بنشوف المناسب، بنجيب شغلات خصوصا مشان مرض السكري. اول ما طلع معي السكري حسيت إنه تعبان، اتجأت للصيدلي حلل لي وطلع معي السكري 320. قال لي بدك تدير بالك على حالك وبدك أدوية وبدك تحلل، وصار له هلأ معنا شيء 25 سنة.
Lebanon is currently at the forefront of one of the worst humanitarian crises. With the war in Syria now into its 10th year, the severe economic crisis that hit the country since 2019, as well as the COVID pandemic and lastly the Beirut blast, have put additional pressure on its healthcare system. In Lebanon, 1 in every 4 residents is a refugee, and the consecutive crises have pushed these vulnerable communities further into poverty. Half of the households, whether refugees and host community, report at least one member who suffer from a non-communicable disease.
أعطوني أنسولين، أباخذ أنسولين لنشوف بنمرق على المستوصف إذا في أدوية بيعطونا، ما في أدوية بيسجلوا لنا على دواء.
إذا ما في حالياً بدنا نضطر نجيب من الصيدلية.
إن شاء الله ما هو مشكلة. وين بدنا نشتري دواء وين بدنا ناكل ونشرب وين بدنا ندفع أجار بيوت. أمور صعبت علينا كتير كتير كتير.
Diabetes requires continuity of care. And in settings like humanitarian crisis, where interruption in accessing healthcare services can have severe repercussions on the condition and the outcomes of the disease.
هذا أثر على علاجنا. هالشيء هذا أثر على نفسيتي تعبت شوي وارتفع مع السكري وارتفع مع الخزي.
The ICRC has established multiple partnerships with the private sector as well as academic partners to ensure better access, quality and continuum of care for patients that suffer from NCDs living in humanitarian settings.
مسجلين نحن بالصليب الأحمر هون بالميناء. يا أهلا.
وكيف حاسس حالك هلا عم تنتبه على حالك؟
حاسس حالي بنتبه على حالي كتير.
كأخصائية اجتماعية دوري يكون عم بقدم الدعم النفسي الاجتماعي للمستفيدين، ففي كتير مستفيدين بيجوا بيقولوا لنا انه انا مش عم بقدر اخذ الدواء، مش عم كمل بعلاجي لانه انا ما معي ادفع مصاري، او اني اقدر اكون عم جيب الدواء لانه هو مش متوفر، او وضع المادي ما بيسمح لي اني اكون عم جيب الادوية. انتوا عم تاخذوها تقدروا تاخذوها هلا ما توقفوا، يعني ما تكون عم توقف دواء. ممكن يكون عم نلاحظ عند الاشخاص عم يعلى السكري عندهم.
اوكي شكة صغيرة مش حتكون كتير كبيرة، ما تخاف.
اهم شيء نكون نحن الاشخاص يلي هي عم تجي بيكون في اكيد توعية عن موضوع السكري والوقاية، كيف هن ممكن يكونوا عم بيعملوا وقاية.
بتحكم بعلاجي وبالدواء نظام، باخذ دواء بنظام، والاكل خصوصي للسكري. النفس بتشتهي السكر، بحاول بدي اكل منها، المرة لا.
ده لها الطبخة طيبة ولا مو طيبة؟
طبخة طيبة كتير كتير.
Our hopes for the future of NCD patients in Lebanon are for them to receive better access for quality healthcare services, for quality food, and to be able to reach them at the preventive level rather than focusing on the curative. Through these partnerships, we hope to improve the quality of life of the displaced living with non-communicable disease, and then change can come.
بعد الظهر نحب نتمشى أنا والمدامتي، نطلع على الكورنيش. برافو. أمور بنلاقيها كتير كتير كويسة. حابب السفرة لبرا أنا والأولاد، بس أنا بالنسبة لي ما صار سفرة لبرا، على سوريا. بيتنا مدمر، بدنا نحاول نصلح فيه ونسكن.
What a great quality movie. I hope you all have enjoyed watching it, and sort of really gives a lot of colors of the situation in the region, the kind of patients we're dealing with, and then also the concerns and the human face of the disease. And I think I hope that we get to see more videos like that. Our next speaker in this fireside chat that I will actually try to shorten to sort of catch up with time, but Dr. Claudia Trupa, she's a health coordinator at the International Committee of the Red Cross. She's very familiar with those settings. Working in sort of humanitarian context is a daunting task, dealing with the complications of the disease of health system, but then more importantly, that context makes it extremely difficult and makes her insight very valuable. Dr. Claudia, welcome to our event. We're really happy to have you. We would love to hear from you, basically, and from your experience. How can government, multilaterals, everyone, private sector, the NCD community, help put this human face and people-centered approach? And this is something that Maha called for in her opening remarks. How can we make it happen, Dr.?
Good afternoon, and thank you, Dr. Ziad. I think it's very nice to start this conversation immediately after this video, because in this video was my colleague Carla has a bit described already some of the key issues that we're trying to tackle as the International Committee of the Red Cross here in Lebanon. I will try to describe perhaps how we came into this partnership, because the ICRC has been actually present in Lebanon since more than 50 years and has been responding to the Syrian crisis since 2014. And we've been adapting our response continuously throughout all the colliding crises that have hit the country, particularly over the past 2 years. And a strong focus of our response in terms of healthcare services support has been, of course, on guaranteeing continuity of care for patients diagnosed with chronic conditions. But shortly after implementing our project, we noticed the first key missing element in the methodologies and tools available to both design and then monitor NCD intervention in humanitarian settings. And this was that patient's voice did not really appear anywhere. There were data available, there were assessments published at country level, but all of this was mainly facility-based. Indicators were mainly process indicators rather than outcome indicators, and the patient perspective did not appear anywhere, at really little space. We all knew how many consultations were being done for patients, but we knew nothing about patients who could not make it to the consultation. So we started asking ourselves, why were they not coming? Which were the barriers they were encountering? And how could we possibly reach out to them and bridge those gaps that they were facing? And that's how we've decided to start engaging with the communities in the catchment areas of our supported facilities, and then with the Ministry of Public Health, and then with other actors, private sector, academic partners, as Carla was mentioning, to move towards a more people-centered approach in identifying the needs and gaps in response. And well, easy to guess, but patients and communities have given us all the answer that we needed, because it was thanks to them that we've been able to promote a model of care that does not address chronic conditions in a vertical fashion, but rather that tries to incorporate it across the continuum of care services available. And this means from community focal points that were trained in delivering psychosocial support sessions to primary healthcare centers that served them and that were supported with incentives for key human resources or supplies, to the physical rehabilitation centers where patients with uncontrolled diabetes, for example, were often receiving prosthetic services after facing complication of their condition. We've integrated mental health and psychosocial support in our care delivery model after witnessing how high the toll on mental health can be for these patients. And that many panelists have already, by the way, highlighted way before me throughout this conversation. We've learned also how central the role of the family is in addressing the mental, physical, and financial burden of these conditions for patients and his network. And this is, I think, quite a peculiar feature of Lebanon and the Eastern Mediterranean region in general. We've tried to remove financial barriers through subsidization packages so that care could be truly affordable also for the most vulnerable ones. And through these learning with and from the patients we're serving, we're now seeking ways to include NCD prevention and care also across sexual and reproductive health services, for example, targeting women because they are the educators, they are the childbearers, they are the cooks for the family, they are the carers for the elderly. And such transversal integration has truly multiplied the entry points into care for NCDs for patients. And this for us was a way to putting them back at the center. And since 2018, we're partnering with the American University of Beirut and the London School of Hygiene and Tropical Medicine. And this is the partnership that was mentioned in the video to formally evaluate our model of care in order to strengthen it and tailor it more and more to the needs expressed by the patient themselves, rather than to our own assumption. And through putting patients' perspective at the center of operational research in protracted crisis, this partnership is really hoping to bring evidence to the global debate on how to build a humanitarian response that can be truly patient-centered. How we can bring back patients' voices and experience at the center of the literature that is being published on the topic, and how we can document successful experiences as well as learn from the mistakes. So through this process, we hope to just bridge the gap that often arises between policymakers and theoretical frameworks on one side, and the delivery of humanitarian operations according to those same frameworks on the other side. This kind of partnership has been an enriching journey in which all actors involved, I think, have learned a lot to get out of their comfort zone. And I would like to share exclusively the summary of a success story. But the truth is that this type of partnership is a continuous conversation that takes time, takes energy, takes commitment for all the parties involved. It requires adjusting to the different languages that policymakers, academics, and humanitarian actors speak, find a common one, accepting to either slow down in our case or to accelerate based on priorities that often differs among the different actors involved, and then learning to conjugate the need for in-depth analysis on one side with the need of urgent responses on the other side. It forces basically everyone to adopt a cultural shift in perspective and to fit the long-term care needs of NCDs with the yearly planning cycle and funding constraints that we often face as a humanitarian organization. But it truly allows to shape humanitarian programs around the needs of the patients, and it gives them back their voice and dignity. And that in itself, it's an objective that I think is worth it all. So thank you very much for listening, and back to you, Dr. Ziad.
No, thank you, Dr. Claudia, and thank you for doing the work you're doing with such a friendly, supportive, and inspiring sort of attitude. I really feel that the ICRC has put the right person in the job if we want to bring a human face to the quality of the intervention we're doing. I think you're doing an excellent job on that front. We have a fireside chat session. I would encourage you all to send your questions on the chat box. We have another fireside chat session after our second panel. I'm inclined to combine the two questions together, the two sessions together, just for the sake of time. I would just take one question, basically. And this one question is coming from Rania Azmi. Dr. Rania is a UICC member, and she's with FADIA Survive and Thrive. And her question is open to all the panelists, but I would just have one person jump in. Basically, she's asking if there is one thing you would call for changing or alarming us to pay attention to as patient advocates, what would be this one thing? And I think Dr. Ibtihal could jump in here.
Yeah, of course, calling for putting patient first. This is my call for today. You know, we've been talking of full meaningful engagement of the patient. So I think I would love to have more engagement of the people affected with non-communicable disease. And that is a priority. Easy said, but not done. I mean, we have to find a way of engaging people fully. Yes.
Yeah, I agree with you, Dr. Ibtihal. I always worry about putting people first can mean so many things to so many people.
It means a lot, but we have to find a way to translate it and unpack this into and make it very clear for policymaker as well as the health professional.
Okay, let me challenge you here. How are we not putting patients first?
As Omar just said, you know, Omar, when he talked about it, he said, you know, like, I have learned through my lived experience, it is not the priority which has been given for him in the health system. And I think the other one, which is the going to hear from a Syrian refugee, you could see how he could explain by his simple word that he was not a priority in the health system. And we are not looking for the need of the patient in terms of the health system as well as other things. So we need to look at it, how we can bring people, these patients, and listen to their experience and modify the system modify the care we provided based on their needs and experience.
Okay, I will not take more of your time. I'm looking forward to hearing actually this
other perspective. Yes.
Yeah, this pre-recorded audio intervention from Mr. Mohammed Shakhashiro. Let's hear him out and come back to our panelists.
السلام عليكم. كوني سوري لاجئ في الأردن ومصاب بمرض السرطان لدي تحديات.
As a cancer patient in Jordan, the most important thing is to find the medication. Medication for cancer patient is difficult, and there is no place that can provide us with a medication. During the COVID-19, it was much harder, especially after I became jobless because of my disease. And of course, I can't go out. There is no place, no department can help us with this. So I have to stay at home. A cancer patient have to be part of the decision-making process and in how to healthcare, because he will have experience, and they're really difficult to find the medication. There is also important to focus on the medication and the treatment, and to take in consideration the patient's medication and treatment. So to improve the situation of the patient, and thank you very much for letting me share my views. I really thank all the Cancer Research Center.
I hope our colleagues were able to switch to the Arabic interpretation, but I think this testimony is very powerful. I really appreciate everyone in the organizing committee to kind of have managed to share this recording and produce it with us. Hearing patients explain what their needs are is actually, as Dr. Claudia said, is the right way to go. And that's where they give us the answers, and our job is to implement it. So I'll move to our next panel with Dr. Suraya Ramul and Mr. Khurram Hashmi. I'll invite them to reflect basically on what we have heard so far. And then also highlight some of the lessons learned moving forward in terms of untapped opportunities of collaboration between all of us to find the answers that we need to find to put people first. Mrs. Soraya, very happy to have you today.
Thank you very much indeed. And thank you very much for having us and also allowing me to contribute to the discussions today. I also wanted to say that, you know, we as Novo Nordisk, we have supported the EMERO Regional Alliance since it was founded. We have previously been supporting our View as Our Voices initiative, because we think it's important to find ways of bringing the voice of people living with NCDs at the forefront of the discussion. In particular, what we are keen on is to get the opportunity to bring forward the voices of some of the many refugee and other displaced people living with a chronic condition, especially in the region, in the Euro region. And I'm happy for that reason to hear, obviously, that many of the speakers have highlighted the need to include vulnerable communities such as this one in focus, also as part of the global charter that is now being built based on your inputs and that of other regional dialogues. So we in Novo Nordisk, we have a focus on access to care for vulnerable people and communities. We focus on diabetes in our case, but you know, you asked for learnings in terms of COVID-19, and we have a few as well. But the most important one, I would say, is that the private sector contribution is needed more than ever. You know, we talk a lot about private sector having a global presence, also resources, but also supply chain networks that are very strong indeed. And this has been put to use during the COVID pandemic, obviously, and is still being put to use. There were a lot of confusion and disruption as we and still are. But I think the private sector has shown a high level of agility in terms of response. The challenge we have really now is to move beyond what is an emergency response and take stock and also use those learnings to build health systems better. And I think with that, people living with NCDs have a critical role to play in advocating for a people-centered approach. But let me provide you with, I hope, some concrete examples on how we as a private sector have taken this person-centered approach. The first example has to do with our core role, which is especially as we were faced with this global pandemic, how we ensured a continued supply of insulin. So as you know, many people were living with NCDs, including diabetes, were vulnerable in terms of access to care already before the COVID-19 pandemic happened. But of course, this was exacerbated, and what happened is that we were faced with many requests of emergency donations of insulin for countries who had experienced difficulties ensuring supplies due to the interruption of transportation. We also have long-term agreements with humanitarian organizations and other UN organizations with whom to whom we supply insulin. So what we have done is that we have worked and really used our strong network to be able to find alternative ways of getting the supplies to the patients, even when there were disruptions. So we were able last year to provide approximately 1.3 million vials of insulin to more than 50 countries. So that's the first example in terms of continued supply of insulin. The second has to do with a partnership that was mentioned already, which is Partnering for Change, and that's in partnership with the International Committee of the Red Cross, the Danish Red Cross, and also supported by our academic partner, the London School of Hygiene and Tropical Medicine. So what we're doing there to ensure that we have a patient-centered approach is that what we want is to find better ways of providing chronic care for people affected by humanitarian crises, and of which, of course, unfortunately, there are many in the Emerald region. We've just seen the film, and it has given that human face that is generally highly overlooked and deserves more attention. So that story of Abdel, I think, was very compelling indeed. So as part of Partnering for Change, we are looking at how we provide care for diabetes and hypertension. But the way we do it is that it is done through interviews with people living with NCDs and amongst others, refugees. And this is done by the American University of Beirut. And there the person-centered care is really critical. So that's another example. And lastly, with the last seconds that I have, the third example has to do with a program that we have around type 1 diabetes, and it's called Changing Diabetes in Children, where we provide patient education material for children. And that program is being significantly expanded, including in the MO region, starting with Pakistan. So in that program, we're trying to provide digital solutions to scale efforts, because really what we want is to integrate those solutions into health systems. I cannot emphasize that enough, that whatever we do is in partnership, and the primary role is really for governments and civil society to really build health systems and really leverage the learnings that we have. So we are part of that effort. But for scalability, I think we will need to go beyond those fragmented initiatives. And we are keen on being part of a discussion where we can find, avenues, platform where we can actually ensure that concerted action rather than trying to leave this fragmented action that was needed as part of the pandemic, but we need to move beyond that. So with that, I'll end here for now, and I would like to thank you very much for your attention.
No, and thank you Novo Nordisk for supporting this event, this activity, but also I work with the Helmsley Trust, and I can testify of your commitment to make insulin available globally, and I've seen that in action, and I really commend you for your work on that front, and I hope you'll continue your commitment with a deeper dive into the EMRO region, and thank you for collaborating with AUB as well. Please, if you have any questions for Mrs. Ramoul, please send it in the chat box and we'll tackle it as part of our fireside chat. And as we've done earlier, we have taken a deep dive into the situation in Afghanistan. Now we'll go a little bit west of Afghanistan and go to Pakistan with Mr. Hashmi. And Mr. Hashmi is the technical advisor for the Union Global Implementation Program in Pakistan. He works on the provincial level, he works on the national level, and I think we've been seeking colors from everyone participating here to tell us what's happening on the ground. Mr. Hashmi, you have 6 minutes, but I hope you will be brief. We really want to know more about the communities that have been affected by the pandemics and how your organization has adjusted its operation in the midst of this pandemic. And I think you're on mute, so if you can unmute yourself, I think that will work.
Yeah. Thank you, Dr. Zaid and NCD Alliance for this opportunity. Our association with the EM region goes well over a decade now. And yes, it is pertinent to have such sessions considering the dynamic changes and challenges of COVID-19 and its effects happening in our lifestyles, respective lifestyles, not just limited to Pakistan, but in the region, as health systems have been constantly compromised and they need to be strengthened and coordinated accordingly. It has been a constant learning experience for all of us since its start. Much has been already covered with respect to the NCDs, pandemic, and efforts. When we talk about the LMICs, low middle income class countries, and especially countries like Pakistan and Afghanistan, the statistics and situation are not very different. And that these countries are already struggling with the economic and health challenges. The pandemic has taken its toll, particularly on the low and middle income classes among the communities who are trying to survive on daily basis due to their nature of work and lifestyles. These communities are most affected and exposed as they do not have the choice to stay at home and manage their families. With their survival at stake, the pandemic has increased their already challenged life with even more to the extent where they have to be out and about, and that too without the necessary protection, let alone the luxury of the vaccination available. Like globally, the health burden lies among these classes, as well as alongside with the existing NCD challenges, including the mental health care. The pandemic fatality intensity is also reported within these classes more and higher in number. The government, whether for Pakistan or Afghanistan or anywhere else with their limited resources, considering we are talking about the government with the LMICs, the government with its limited resources is very much relying upon the community support to face the pandemic under the identified SOPs, whatever and however they are defined according to the situation, as well as with the international support in form of the vaccination and medical healthcare support. The link between the NCDs and household productivity and low income is now well established. Although ill health nearly always lowers the household income, household affected by the NCDs experience greater income loss relative to the household. These are being reported in general infectious diseases. This is because the expenditure associated with the acute and long-term effects of the NCDs are higher, resulting in catastrophic health expenditure for the household. And this is an area which has become very much challenging in the times of pandemic. When people are being hospitalized with the chronic diseases, now the hospitals are overrun by the poorer who have been exposed with the COVID-19 cases, and the fatalities have increased. And in many cases, all of these, the deaths, the health cost, it all compromises to the mental health to the greater extent, not just for the communities, but also for the authorities themselves. And another challenge remains in the general public. Despite going through the third wave in 1 year's time, we are still in denial of any ongoing diseases or outbreaks. Thus, acceptance of getting vaccinated has also become a challenge from this particular community's perspective. They need to work on daily basis and out the community in order to get the basic necessity to survive the night. And then there are poor who relied upon others' help to even get score for one time's meal. This class does not even have the access to the basic healthcare, and is the most affected and infected that sustains the outbreak and slowed down the overall progress and efforts taken by the governments and other stakeholders involved. The government's response to the coronavirus is subjective to the community support in form of the compliance of the SOPs. That is it. Otherwise, infinite and continuous lockdowns affecting all livelihoods around them in order to protect not just the community, but also the frontline health workers who are still at risk and at large exposed to a particular chunk of community that is still in defiance and has become a threat for them. Here, the role of the community participation becomes vital for a collective response in support to the government in order to overcome the crisis under the necessary steps. In case of Pakistan, I'm sure the state is trying to strengthen the healthcare systems while trying to sustain the economy by keeping the necessary businesses open that particularly involve these low and poor classes. The intention behind the effort is to save as many lives as possible while keeping the fire burning in the household through provision of food and healthcare. As you know, that more than 60% of population live under the poverty line in Pakistan. That presents a drastic situation where the government is trying to manage through strengthening of the healthcare systems. A comprehensive NCD plans, yes, it has been developed. And it has taken the provinces and states on board to counter the outbreak by equipping the systems with best resources, human and medical, available in Pakistan at the moment. The role of the civil society and community becomes pertinent to support the SOPs through the compliance and looking out for each other by spreading the right information and access points, as well as identifying the gaps in the existing system. And our organization, the union, is basically working with the government and communities in the same context. However, the scope of our work is focused on tobacco control. As you know, tobacco use is being one of the highest risk factors for NCDs. We are working for developing and strengthening the health systems and having adequate policies in place that can contribute to saving lives in the ongoing pandemic. With support from the community, their positive responses and acceptance, the outreach can increase many times to the extent of the less accessible or overlooked areas in the communities. The NGOs can play their volunteer role. However, under the stress of the pandemic efforts, if the sustainability of NGOs were even a concern before, now, more than ever, sustainability of NGOs is at stake, and that can only be managed through supporting their efforts through financial and in-kind funding. The communities and NGOs have long and vibrant history of working together with the government to overcome the challenges, and here as well, NGOs are playing their supporting role under a very challenging environment that has put them at risk and at the front line alongside with the healthcare workers. So yes, there is a need for such dialogues to gather intel, insights, and ideas from diverse experiences in order to develop a basic and central healthcare setup and systems that has the outreach to all regardless of the status in order to truly overcome the challenges at hand. The successful models from Dubai, Australia, and New Zealand can be referred and incorporated with the best practices defined by the WHO for healthcare, can deliver the desired outcomes in a most efficient time. The need for funding is undeniable, as we have been pointing it out since the session, as the priority of the world right now should be to survive this together and have a long-term solution. Already a mark crossed and cost of billions of lives worldwide. Only working together, utilizing the diverse expertise may be the only solution. NCD data remains a serious problem, not just in Pakistan, but in the surrounding countries, especially in LMICs, in terms of everything ranging from the disease surveillance to risk factor surveillance to data on spending and financing. We need more information, more data, more solution against the baseline that has been established with the updated information and dynamic partnerships among the stakeholders. Partnerships and networking between the government, NGOs, communities is emphasized, sustainable funding is required, and constant coordination through exchange of information is needed in order to address the situation and persons, especially those who are living with the NCDs. This seems to be the only approach where we can be of any support to the victims, to the persons living with the NCDs. This is it. Back to you, Dr. Zaid.
Thank you so much. Thank you for really going through these different issues that are crucial. It gives us an idea on how difficult it is to navigate the current situation in Pakistan, but also elsewhere in the region. I'm happy you referred to some of the best practices that we can get some inspiration. And I saw you mention that some of these best practices are actually happening in our region as well. So thank you so much for that insight. Please, if you have any question for Mr. Hashmi, feel free to send them in the chat, the team, and I will be able to get back to you before the end of the session. I see Dr. Mohammed Sobhi lined up. I will go to Dr. Mohammed Sobhi because I know he's also on call and he might drop at any moment. So I'm really grateful for your presence. Professor Sobhi is the president of the Cardiovascular Research, Education, Prevention, and he was the past president of the Egyptian Society of Cardiology. We're really lucky to have you with us for this dialogue, Professor Sobhi. I think a lot has been said, and basically, I think we did not hear the views and thoughts from people who stand from the same position where you stand. You've spent your life treating NCDs. You spent your life advocating for more investment in NCDs. We're interested about this NCD Academy you're putting together. Can you tell us more about it?
Okay, thank you, Dr. Ziad. I think it's, I'm sorry, I just started and then go to some cases and then come back to you. But I enjoyed all the talks. My position now is the steering committee, Assembly Steering Committee of ACC chapters in Middle East and Africa. And this imposed to me going into more details in the academy. Before I start with this, I will show that what happens in the pandemic. Actually, we have 54 African countries and we have 17 countries in the Middle East. Egypt, for example, it's my country, about the population is 100 million. We have a problem during the pandemics that more morbidity, mortality is not like Europe, but start to increase and then decreasing. Less exercise, less water, concern about cardiovascular high risk concern. So and the effect on the society and the continuous education because there is no face-to-face interaction. So what will happen? This you have to make a public awareness regarding the patient-centered approach and patient support resources, even the doctors itself. So this is what happened in the problem in our country, and also culture and political diversity in also Egypt and different parts of the Middle East and Africa. I will take Egypt as an example of assessment of the barriers. They put the information system at one barrier. We don't have a good database. The medication access is not 100%. Also the finance. So Egypt put what's known as multi-sector action plan, and these multi-action plans, including the SWOT analysis. And this SWOT analysis, I'm going to illustrate to you that strengthens the last stepwise survey was only in 2016-17, where the health system, strong infrastructure, well established, but we have a national population-based survey. This is the strengths, and some diabetes-related stress. But we have opportunity about the cost-effective solutions, about lower economic impacts of NCDs, implantation, surveillance, about morbidity, mortality. But we have weakness, no data available in CBD, morbidity and mortality, particularly chronic respiratory disease, lack of morbidity data, accuracy of current data. But so the threats, this huge gap, the mortality, high fragmented services, and tobacco company control within countries. This is what puts the country to put what's as known as Egyptian nation action frameworks about what's known as health of 100 millions, supported by our presidents. He succeeded to improve the health during even the pandemic start. And also one activity priority is called Stand Save Alive, which I was lucky to be the ambassador of this in Africa. It started in Egypt, and now the ambassador Stand Save Alive. So we continue doing primary PCI in spite of the pandemic. Apart from Europe stopped. But we don't stop it. And even we published this in the last meetings, in the Stand Save Alive meetings with Christopher Nover. About the primary care, also providers' activities also increased. What about NCD Academy? I shared with my position in the ECC to have a lot of webinars. These webinars in NCD Academy are aiming to do continuous medical education of good quality, and this will make it on the app, and more videos. I shared more videos, more accreditation, increasing the quality and quantity. And so there is a need of cardiovascular NCD Academy locally. So my role in maybe spreading this or dissemination of NCD in my country and also Middle East and Africa, together all the governors in the chapters, and also doing some videos either personally or some patients, this increases the public awareness, particularly with some accreditation. This is very important, which was lacking to do this. So I think we succeeded in NCD Academy. The ECC representative with I saw Bryson here in the screen is the man behind the scene. He's doing everything with me and with Niall. I think it's a good opportunity of the ECC to have such alliance. NCD Academy in all our countries. I said 17 countries Middle East and 54 countries Africa. In spite of 2 years of pandemics, we succeeded to increase. And this is evidence in the questions and the chats, the accreditation, the questions to us. I think we are going to continue this. Before the pandemic, we'll make it physically, but I think in this year, we'll continue this in the ECC Middle East. So I have the honor to be the chairman with Dr. Tariq Helmi from the ECC and deputy the president of the American College of Cardiology to make in Cairo, 13 to 15 of October, ECC Middle East, together with NCD Academy. And thank you very much for listening to me. I'm ready for any questions.
Thank you. As a real cardiologist, you went straight to the point and you shared so many information. We're really lucky to have you on the event, to sort of like on the dialogue, to hear about opportunities for people who are part of our region. I'm really happy to have also Bryson from ACC. Bryson, you're managing a lot in the global sort of work for the ACC, and we'd love to hear of more opportunities, or if you can add more to what Dr. Mohammed Sobhi has said related to the academy.
Sure. First, thank you so much for having me. I know that we only have a couple of minutes, but I'm happy to sort of expand on Dr. Sobhi's remarks concerning the features of NCD Academy and the objectives that we're trying to achieve in partnership with NCD Alliance through this initiative. NCD Academy is really about making quality continuing medical education readily accessible to more doctors. The status quo with professional development is that travel is often involved, or there are fees associated. These represent barriers that ostracize, frankly, a lot of clinicians, especially those in rural environments, from keeping their skills fresh. And this is a problem because medical science is constantly advancing, guidelines are constantly changing, and they're becoming increasingly nuanced, showing intersections between non-communicable diseases as well as communicable disease. So we're trying to build a solution through NCD Academy by bringing education to providers through a free app. There's also a website version. When clinicians access NCD Academy, they find courses that are built all around e-learning. Oftentimes, on-demand education is not a novel concept, but oftentimes it's very one-dimensional. You'll have videos and that's about it. With NCD Academy, we want to make the experience really interactive. So there are patient cases, there are games, through an on-demand learning environment. There are ways for learners to apply skills to real-world scenarios and reinforce their knowledge. So we think that's one of the really special and important features. The intersectionality of NCD Academy is also a huge focus. In addition to NCD Alliance, is a really important partner of ours. We're also working with the likes of the American Society of Clinical Oncology, the World Psychiatric Association, in order to cover other really prevalent but preventable non-communicable diseases. So we've been able to have really meaningful impacts in the Middle East through support from Dr. Sobhi and other experts in the region to ensure that we are including modules that speak about issues like hypertension and cardiovascular disease as they're experienced and managed by clinicians in the local healthcare system. We have new courses coming up. The idea is that this will continue to grow and evolve, and we hope that more doctors throughout this part of the world will add it to their phones and start taking the courses with us.
Thank you. We really appreciate opportunities like this. It sounds like it is an opportunity for all clinicians and not those who are interested in cardiology to kind of join and get to benefit from this world-class level of education. I will ask all my speakers now to turn on their videos and come in a sort of speaker gallery. We have 8 minutes to go, and I want us to have a conversation on what would be sort of like your final thoughts on how we go from here. We've been hearing a lot of insight from all of you. There is a focus on putting people first. There is a focus on working together. There is a focus on sort of like using COVID-19 as a moment to kind of transform. And I really was impressed and very much excited to hear Dr. Maha's thoughts in this space. Use it as a moment of transformation, she said. And I think we need it now more than ever. So if you have any questions, and I don't think we have received any in the chat right now for our speakers, I would love for us to kind of like come together and have some final thoughts. Dr. Asmus, where do we go from here? And quick, no more than 30 seconds.
Sure, thank you very much. Well, as mentioned earlier, we will certainly try to do our part to reach out during these special times. We have the digital means available as demonstrated today. I'm also very happy to say that Dr. Ibtihal is currently back in our office here in Cairo, and just today and the last couple of days, we have been engaging with our regional director, Dr. Ahmed Al-Mari, on intensifying our efforts to reach out to civil society, the different constituencies, during these special times where we cannot be, certainly from our regional office point of view, in every country all the time to talk about these issues, specifically on NCDs. But of course, we're not only talking NCDs, we're talking the whole health sector, and it will be a joint effort. There was just one reflection, one thought that I had when I listened, and that was, I think, the potential of the education sector and the need, in my experience, having traveled the world for health and public health, to reach out to health professional education systems early for nurses, for doctors, for other health professionals, and ensure that we become better in listening to patients. To be honest, I've seen very different listening skills in health professionals through my career in different parts of the world, and sometimes in one and the same hospital, of course. And I think this is where it all starts, sharpening our ears, allowing patients to speak and getting the right messages. And that will also, I think, make our approaches more friendly to patients and needs of NCD and mental health patients. Thank you.
Thank you. And happy to hear Dr. Ibtihal is back WHO. So now she's not only the advocate we know, the global leaders we know, but also she is part of the WHO dream team tackling this issue. I really want to hear your thoughts, Dr. Ibtihal, but Dr. Asmus and everyone on the call, we have a major global event, which is Dubai Expo, happening in the region from October till April. And I hope we'll be able to leverage it to bring experiences from across the globe and have similar conversations like this one happening in our region, so we can sort of like continue this dialogues on a global basis and use this big convening of world leaders and the strong WHO presence that we will have there to kind of like move the conversation forwards. Sorry for plugging in the expo there, but Dr. Ibtihal,
yeah, I think Ziad, you know, we are grasping any opportunity to say and to transfer, disseminate our messages. So, I mean, the speakers have rightly said that NCD is a complex issue. So let's tackle it one by one. So the context of our today is patient engagement. We are using this opportunity to highlight the issue, and it's very well highlighted by different sectors. So the lesson learned, I think it's rightly said by Dr. Asmas, WHO is working and ready to work with civil society. And that is a great opportunity for civil society to be working with such leader in public health, highlighting the need in the region and also having other sectors working with us. This is a great opportunity to do. I am optimistic, and we will continue. There is a long way to go, but we will continue advocating for a different area. One area which we need to emphasize today and tomorrow is the need of the patient. We need to listen to the voice of the patients.
Can't find better words to end this event. I really want to thank you all for contributing. Thanks the organizers for putting an amazing lineup, a lineup that represents our region, but also represents the latest development on the globe. Many thanks to the ACC for the work you're doing. Dr. Subhi, please keep it up. We also look forward to continuing to hear about your initiative. Mr. Hashmi, Dr. Abdullah, we're really excited to hear from Pakistan and Afghanistan. I look forward to connecting with you all very soon. In the meantime, please enjoy the recording and share it with colleagues who are not able to join us. Many thanks to Novo Nordisk for supporting the event and the multi-regional dialogue. And many thanks to our friends at the NCD Alliance to be such a great convener and organizers.